Hello, and thank you for joining the latest iteration of OrthoBrain University webinars. Today's guest is Dr. Kurt Doolin, and we are pleased to present his information about restorative dentistry and ortho-restorative dentistry. Today's presentation is titled Orthodontic Therapy for Aesthetic Restorative Dentistry. And I'd like to take just a moment to introduce our speaker, just as soon as I get through this disclaimer. The opinions, recommendations, and best practices shared during this presentation do not necessarily represent the opinions or recommendations of OrthoBrain, but are a representation of clinical experience with Simply Clear and are solely the opinion of the presenter. This presentation is intended for education only and should not replace independent professional judgment. Today's speaker is Dr. Kurt Doolin. Dr. Doolin received his BS in microbiology from Michigan State University. He received his DDS from the University of Detroit School of Dentistry, and he completed a GPR at the University of California at San Francisco. Dr. Doolin has also studied with Dr. Mish at the Implant Institute, Dr. Picos Implant Institute, the Las Vegas Institute, Dental XP, the Center for Dental Ceramics, and I think we're going to hear just a minute or two about that, and also with OrthoBrain. It is my pleasure to welcome today Dr. Kurt Doolin. Dr. Doolin, how are you?
I'm good, David. Thank you. Good to see you again.
Likewise. Thanks for joining us.
Good to be here.
Excellent. So tell me a little bit about your background.
Okay. Well, you've covered some of the good stuff here, but I'd like to say that my background at Michigan State and at UOD was pretty basic, same as everybody. My residency at UCSF was interesting in that it was very surgically oriented and oral medicine and things like that, and anesthesia. And it really gave me my kickstart into implant dentistry. This was back in the day when this was all very new and not, you couldn't find education on the topic anywhere that was clinical in any way. And so that got me started down my surgical road. And I made a decision to skip the oral and maxillofacial surgery residency that I was thinking so seriously about, and go on and become surgically trained to be a more comprehensive restorative dentist, because I enjoyed creating a final product. I liked what was happening. I saw new stuff coming in dentistry that was more aesthetic than the way I'd been trained, and it was kind of a fun way to go. I got out of school. I came back to Michigan to see my family. I had a position all ready to go in San Francisco. And I came home and said, I think I'm going to stay in Michigan. And I did. And I started a practice from scratch, close to home in the suburbs of Detroit, which are like suburbs everywhere. Anyway, and then we went on and got more education at the Mish Implant Institute. And Carl, God bless, was a neighbor, really. And his office was just around the corner from my house. So I had some interesting interactions with him back in the day, and Dr. Picos, and then all of the aesthetic things that were coming around in dentistry. I had heard about the Las Vegas Institute for Advanced Dental Studies and went out there to further my aesthetic knowledge. And oddly, it was there that I met some of the smartest people I know today, even in dentistry, and still work with them closely at the center and at the OrthoBrain headquarters. So stuff comes around, full circle.
Sure does.
Yeah, and I'm a big Dental XP advocate. It's probably the best online training system that I know of. At the center in Ohio, we are an affiliate site for Dental XP, and are running live courses there for them. And I'll talk about that a little bit as we move along. But I started a private practice from scratch back in an era when you could probably do that and not, be fiscally irresponsible. And I got away with it, and I built it up and I built it up, and I bought a piece of property and I tore down a building and I built this that you see here. And this was Beautiful. My place of business, an 8-operatory first floor and sort of a 3-bedroom condo on the second floor that we use for private offices and daily office team meetings in the morning. And of course, we had a full kitchen, and we had a lot of good times as a team up there. And it was designed to have two doctors and two or three hygienists, and that's the way we ran it, and evolved along the way amazingly. This was on the eve of the digital revolution in dentistry, and it was just people say, "Gee, is dentistry changing?" And I just say, "Yeah, it's moving along at a pretty good pace. Like everything changes about every 15 minutes, you know." And I joke about it, but it's true. And I'm at an age when I could toddle off into the sunset. But with the teaching that I'm doing at the center, I get exposed to some of the world leaders in dentistry. And with the gang at Dental XP, I'm just seeing all of what's coming down the road, and it's so interesting and so exciting that I couldn't stop. But what I did do is I walked away from this practice. I sold the practice to my then partner, and I toddled off to be much closer to my home and downsize. So this thing got big, and it got to be a management issue. You can see our team that I had there for many years. And then we shifted gears as I left town and took a hiatus from dentistry for about 6 months while I built a very, very tiny single operatory practice in another town. And I extracted those two people from this photograph. She, of course, left of her own accord after I left the practice, and worked somewhere else for a while, and then heard that I was opening up a new shop. And now I have the next iteration of my private practice life, which is one very well equipped operatory with a lot of original artwork around inside the rest of the office space, which is fun and aesthetic. It's very, very sparse and clean, I think. And then I have another small room that is a photo studio, as you can see, and a 3D print lab, and all the things that I need to accomplish my modern dental practice. And of course, that was all designed to support this, which is what you see here is a beautiful aerial fall photograph of the center at Dental Ceramics, which in that building is a full service restorative dental lab with all the latest stuff done at a very high level with some amazing lab technicians. The owner, John Levichka. And then also it houses our training facility, and it houses OrthoBrain, which is how this all came together, because that's where I met Dan, Dr. Gurman, and David, and here we are. I was an Invisalign client for many years and had many successful cases, and I had an interesting relationship with them, which I'll go into in a minute. But then Dan Gurman and I met, and we just went from there. He speaks to me so and helps me so much that we've become great friends and colleagues now. But what we do at the center, aside from collaborate with OrthoBrain, is that we run an aesthetic dentistry continuum, if you will. It's a small continuum, aesthetic excellence 1.0 and 2.0. And this course is designed to teach you everything from diagnosis and planning and photography, the photography that's necessary, to laboratory relationships and execution of a full dental case from start to finish. And we are able in the state of Ohio. I'm close. I'm 2.5 hours, so I drive down frequently. But we're able to do live patient care in the state of Ohio. It's not able to be done in many states in the country. And we have our visiting doctors come and bring patients and actually complete their case there. So the 1.0 really cool. It's amazing. I mean, we've done cases, and I'm so lucky because people say, well, how many cases have you done? And I'm like, so many, because I consider every case that I participate with and teach as almost like one that I've been a hands-on participant with, because you learn so much
Right.
by watching, and the doctors, our motto is learning by doing there. And boy, there's no substitute for doing. You can watch all the video you want, but until you are a
Mhm.
hands-on participant with something, that you have to hang your reputation on when you're done, you really
Mhm.
pay attention, and the learning is incredible. So the 1.0 is pretty much a standard veneer type of a course, like I said,
Okay.
with the photography and the design. And then we have a 2.0 level course, which is one that I developed along with my dear friend Jim Harding from Vail, Colorado. And in this course, we saw a need for the cases that came to us for the 1.0 course. A lot of them were severely broken down, damaged, missing teeth, periodontal disease, big time bite and jaw postural issues. And these young doctors wanted to do veneers on these patients because that's what the patients asked for. And we just said, no, we can't in good conscience do that. So we developed this course, which has let's just for ease, let's call it a bite change that goes along with this. There's a lot more involved in that, of course. But, instead of a 10-unit classic veneer case, we do a full mouth reconstruction in a 5-session course with only 3 clinical visits. It's a logistics feat, and it works
Mhm.
very well. And our final results have been nothing short of phenomenal. So we're very
That's
proud of
awesome.
it. Pardon me.
Sure thing. And it looks like you've got a current practice focus here on aesthetic
Yep,
and implant dentistry. So tell us a little bit more about maybe how the ortho fits into that as well.
absolutely. And when we talk about smile design, and everybody wants to talk about minimal tooth preparation. Well, you're not always able to do minimal or no prep veneer cases because the teeth aren't in the right place. I think we all understand that. It's pretty basic
Mhm.
stuff. But
Mhm.
now, with the utilization of digital cone beam CTs, uh, intraoral scanning, facial scanning to decide the desired position of the teeth, we can actually look at these cases now with the help of our lab techs and things, exocad and 3Shape softwares and all of the great digital stuff that we have at our disposal. That, by the way, I am a very minimal operator of, but I have amazing digital lab technicians at the center that do all this stuff for me. And not
Mhm.
only is it done to show what the case is going to look like when it's done, but it helps me in my diagnosis and my treatment planning because I want to do minimal preparation. Oftentimes, the first thing I think of and discuss with my patient is often pre-prosthetic orthodontic intervention
Mhm.
to get the teeth, as I always tell them, I got to get your teeth in the right zip code so that I can do minimal preparations. I mean,
Right.
and I'm not Italian, but I'm Irish, but we use our hands too. But I say, well, if your tooth's tipped out here, I got to cut it off and amputate half of it in order to build back my porcelain to get it to here.
Mhm.
Would you consider gently repositioning this tooth to get it into the right place so we can do very minimal tooth preparation? The patients have great language. They say, well, so you mean you're gonna put my tooth in a pencil sharpener and make it a little cone so you can stick this crown?
Right.
I'm like, no, everybody thinks about things a little bit differently, and they all have a different visual uh, acuity, and things that
Mhm.
they see in their own little movie. And we use all this digital technology to show patients not only what the final outcome can be, the possibilities, but how we have to get there. Do we want to go ahead and grind teeth down to small bits in order to attain the alignment mechanically that we need to put porcelain on? Would you consider taking 6 to 12 months to move teeth around and get them in an idealized position, not just for the minimal tooth reduction, and ceramics that we want to put on. But the why, we want healthy tooth there. We don't want a little tiny bit. I want a bunch of it. I want as much natural tooth as I can have there. I want to align arches. I want to upright posterior quadrants that are tipped over because of a tongue postural issue. Yeah, there's an infinite number of reasons to do orthodontic intervention before this, but we'll go on with some more of that in a bit. But all of this
Okay.
digital business that is modern dentistry isn't just about doing things, faster and cheaper. It's also
Mhm.
about helping us understand what we actually have to do to get from where we are today to an idealized, beautiful, final aesthetic restorative result. So it's
Cool.
really,
Sounds great.
yeah, it's a very prominent tool in the toolbox. It's not just about a handpiece, and it's not just about a large format camera or anything that all of us aesthetic people that we call ourselves aesthetic dentists, we use that. This ortho tool is a big tool in the toolbox now.
Thanks for sharing all that. I think we're going to see it in the next couple of cases.
Yeah. So this is just a kind of a classic upper smile design case. This is a young man who called me up and he said, I'm getting married. I've never liked the way my teeth look. I had ortho when I was a kid, and this is what it looks like. He goes, I think I need Invisalign. And I said,
Mhm.
well, why don't you have your fiance shoot a couple of selfies, and send them to me? And he did. And I called him back and I just said, that you don't need orthodontia at this point. Your teeth are your arch form's beautiful, everything's good. Come on in, let's take some photos. We use a lot of dental photography, as you could see by the small studio that we have. But this guy's teeth look like they're already prepped for veneers, quite honestly.
Yeah,
And
sure.
moving them around isn't going to do anything. So we scanned him, we did digital mock-ups, we did an intraoral, an in-office smile simulation, where we actually do an overlay. At the center, we call it a trial smile. You can call it a mock-up, an overlay, anything you want. But I think the next slide shows his actual trial smile. Yeah, and that's just a simple Luxatemp resin overlay of his teeth. Now, granted, this one's pretty easy, pretty straightforward because of the gaps in his teeth, his tooth shape, his tooth positioning. You have to coach your patient through what they're going to see when you do a live smile design in their mouth. I mean, if you look close at this, you can see little bits of acrylic in between this gentleman's teeth. I did this was 10 minutes maximum in my practice. He looked at it, his fiance looked at it, we photographed it. They said, oh my God, when can we go? And I said, well, how about tomorrow? Because I have everything I need now. I have their agreement that they love what the aesthetic outcome is going to be. And they ask the questions and say, how are we going to do this? How is it going to be done? Are we assured that we're going to get this same result? I said, I answer all their questions and I move on to the next day, if you will, or the next appointment. And then we actually do some very minimal prepping of the teeth, mostly to round things over and create some small finish lines. And then we produce the next slide, which should be his final result there. And yeah, that's his ceramics up close and personal. And
Beautiful result.
these things turn out very nicely. In this guy's case, there was no ortho involvement beforehand because he had it earlier in his life and somebody
Mhm.
else aligned his arches for me quite nicely. So, that was that case. And there you go. That's just a smile, a full face shot before and after. And I think the case turned out quite well. But that's your basic 10-unit case. And then we get on to the 2.0 level course, really, which is a full mouth rehabilitation, which involves a mandibular postural change, meaning as teeth wear and as teeth are lost, we know that there's I don't even like to use the word bite change because patients, we talk to them about what are we going to do? We're going to change your bite. We're going to open your bite. We're going to shift your bite. I think those are hard concepts sometimes for patients to understand. So we speak about jaw posture and where your jaw hangs in space and how the teeth come together. And we want comfortable, relaxed muscles and all these things. And we use a lot of TENS and we use deprogrammers. And I come from a history of physiologic dentistry, neuromuscular dentistry, using all of the instrumentation. In our course, we don't. It's way broader scope than the course that we're teaching. So we're doing this on a simplified method using TENS and a deprogrammer to derive our corrected, comfortable muscular jaw postures prior to our all ceramic occlusal and aesthetic rehabilitation. And it's worked out really well for us.
Excellent.
And then these are just some of the cases that I've done over the years, with full mouth reconstructions. And I think we can all understand that, this guy needed a lot of dentistry, a lot of wear and tear, some implant placement in the posterior segments in this case. And it turned out quite nice. And quite honestly, just put him in a time machine, really. And he got a lot younger and healthier looking very quickly.
Yeah,
And then,
he sure did.
yeah, this is a really nice man, who had a lot of wear and tear on his teeth, worked for he was a cement contractor. And I can't help but think that all of that abrasive dust that he encountered every single day from when he was a kid up to adulthood really got after his teeth. It's also very acidic, all of that Portland
For
cement
sure.
and all that stuff has a very, very low pH and it's caustic. So I think that beat the heck out of his teeth. And so we restored them. And then, there's other people that do need these cases done on this scope for different reasons. Next case, I think, is a younger lady, beautiful. And she had, this is a TMD case that we had to reposition and reposture her jaw and get her comfortable with orthotic therapy over several months before I dared touch her teeth. I wanted to make sure that I had her very comfortable in an acrylic orthotic before we went ahead and rebuilt her teeth. There's a lot more wear and tear there and old restorative material than you can see in these portrait photos, but it's a big case. And then on to a next one, which is just another full mouth case with a bite change. And this guy's that's as close to a Jack Nicholson smile as I've ever seen right there.
Yes, I would agree.
Yeah, and his personality goes right along with it. He's one of my favorite patients ever, and I still see him to this day. So this case was done a few years ago. But today, another thing that we're doing is a lot of tooth replacement with dental implants, and I'm doing single arch, a single tooth to full arch rehabilitation to dual arch. I mean, the All-on X is just the hottest thing in town, and it's for me, it's kind of cringy. I see a lot of teeth taken out that don't need to be taken out. I see a lot of bone reduction that doesn't need to be done. And I think we're going to come full circle on that. That's only my opinion, but we're going to start doing a lot more in the FP1 category versus the FP3 and whatever. But there's a need for all of it at different levels, depending on the disease state and the breakdown of the patient. We do a lot of hard and soft tissue grafting to recreate proper implant receptor sites. We're doing a lot of partial extraction therapy now, which has been is a relatively new treatment modality, and I use a lot of biomodifiers, PRGF and PRF, to enhance my bone grafts and my wound healing. We're not going to go into any of that here, of course, but I think I have one case coming up that just shows the efficacy of a partial extraction case in a single anterior tooth in the aesthetic zone. So I think that's coming up here. Yeah. So, we've got this, that photo is flipped on the left horizontally, but I think we can figure it out. Tooth fractured off, wasn't well restored. There was a broken off post in it. I didn't do this initial work, someone else did, but asked me to fix it. So in the next slide, I mean, what do? You could have put a bridge in there. So we took a CBCT and we saw what was going on. Really large post, not a lot of root canal space or feral capability to get a good retention of a new crown. So we just overlaid a little implant for treatment planning to show the patient what was coming up. And then in the next slide, you can see actually the final result. And this is with a partial root extraction. We kept the facial portion of the root, which kept all of the contours of the hard and soft tissues intact in the facial, because I think, as we all know, you take that root out, it doesn't matter what you do, you're going to be getting some hard and soft tissue contour changes very rapidly that tends to progress over time. And with the onset of this partial extraction therapy that is being done all over the world now, we're getting results like this on a routine basis. So it's very attractive to me. In fact, there's almost, that's, again, when I'm doing implants, the first thing I think of is, what can I keep before I start looking at what I have to remove to get the case moving. So that's kind of fun. And, orthodontia plays into this too, because oftentimes we can use aligner therapy to idealize and ideally position teeth for use to augment our implant cases, which always turn into, people don't come to us and say, I want implants. They come to us and say, I want a beautiful smile. And it's up to us to figure out what the path is. What do we have to do? What do we have to do to maximize the patient's current situation in order to enhance the final result? And in this case, this is a very attractive, very social woman who unfortunately snapped that tooth off, of course, at an event. And, people come to you with a certain level of anxiety about this. And we were able to do this all on an immediate basis. We took part of the root out, put the implant in, got part of the root there, put her into an immediate provisional screw retained tooth. And then we were able to replace that in a few months with a matching porcelain crown. So there it is.
Terrific result.
Yeah, it turns out nice. It's really fun too, because how it is at dentistry. Patients are always concerned about, is it going to hurt? How long is it going to take? Depending on their personality types, they want it done yesterday, or they're more interested in how it's going to feel, or they're more interested in how long it's going to last, or there's an infinite number of issues that you have to deal with patients and their personality profile in order to get through these cases well. So now we can get on to where we are today in aligner therapy. And I gave you a little bit of my history, and that I was an Invisalign guy years ago. I had an amazing relationship with a dear friend of mine who Dr. Gurman also knows in our area, who was a very large aligner office. And I had a unique relationship in that I would have him set up all my cases. And I could call him up and say, hey, I'm trying to do this aesthetic case, but there's a lot of the teeth that are in the wrong place for me to do what I want to do. Can I selectively move these teeth, again, into the right zip code so that I can then do my restorative thing? Just, tell me if I'm crazy, or tell me if you think it's a viable alternative. And, more often than not, he would say, well, yeah, you're a little bit crazy, but yeah, we can do this. If the patient cooperates and does what they're supposed to do, we can get these teeth where you want them. And then you can go ahead and do your aesthetic restorative thing. And he's like, yeah, I get it. I think we can do it. Well, then he started moving away from dentistry and getting into retirement and later on in life. And that just about happened at the time that I met Dr. Gurman and began my relationship with OrthoBrain and Simply Clear. And it was a great transition, because what OrthoBrain does is basically the relationship that I had with my dear friend, and it was definitely not the standard Invisalign relationship that I had, because I was dictating what I wanted and asking a trained professional if it was feasible. And that's the kind of hand holding that I get now with OrthoBrain. And that's just where it is. That's where it's at for me. That's a relationship that I need. I am by no means an orthodontist who I'm more dentist than ortho. A lot of people that are dentists that produce a lot of ortho in their practice are way better than I am and way more informed than I am. So I really rely on the whole concept that OrthoBrain has as far as education and walking you through the case. And what does it do for me? Well, it gets my obviously my crowding and my malocclusion cases in young adults, but also this pre-aesthetic restorative tooth movement. And that's really where it's at for me, because I'm a highly focused practice now. I don't see a lot of young people in my practice anymore,
Mhm.
unless they're like that one first case that I showed you. But now I'm able to do what I want and ask questions and find out if what I'm proposing is feasible. And it's a huge help for me.
Excellent.
So
Thank you for sharing that.
yeah, I mean, think about all the things that come into an aesthetic restorative case. I mean, the number one thing that I think aligners do best is you can widen out arch forms. You can change arch form. And we see these narrow, high vaulted, high palatal vault cases that are very triangular shaped, airway problems, as you see at the bottom of this slide. But we often have these, we often hear about this in these aesthetic cases. Oh, we've got to widen the buccal corridor. Well, what's that mean? You look at
Mhm.
this, the black triangles that are at the corners of people's mouths. You see sometimes the social six in front, and then you see black behind it.
Mhm.
The classic one we always looked at was Matthew Perry, rest in peace. Friends, he had the social six done by somebody, and
Mhm.
all we ever said was, "Don't do that," because
Yes.
it just didn't look good. Well, so
Mhm.
now I can widen out someone's arch, and instead of putting bicuspid veneers that are so thick in the facial buccal corridor dimension, they're so thick that they provide so much leverage to biting forces that's where failure occurs. Well, now if I can widen out that arch and make it rounder, I can do a minimal prep or even a no prep bicuspid veneer that looks beautiful and doesn't really enter into the occlusal scheme. If we
Mhm.
manage our occlusion with some other anterior guidance and good cusp fossa alignment in the posterior, like we all try to do, we can do a lot more conservative and a lot less risky uh, aesthetic case simply by doing 6 months, 4 months, even 5 months of aligner therapy to widen out that arch form. We can improve facial lingual incisor inclination. I mean, people don't understand. If you've got a tooth that's tipped inward and they say, well, doc, I that one tooth there, I want to build that out. Can't you just stick a veneer on that end?
Mhm.
Yeah, you'll find somebody who will do that for you, but
Sure.
they don't understand that to prep it properly so it's actually shaped like a tooth when we're done, you got to prep the lingual of that tooth and cut the whole lingual of that tooth off right up to the gum line in order to get an inclination that you can work with so that your lab technician can produce an aesthetic ceramic result. Well, gee, why don't we just pump the brakes a little bit here, throw out the anchor for a bit, and do some aligner therapy and get these teeth in the right spot, okay? So that we don't have
Mhm.
to do extensive tooth reduction to get our highly aesthetic ceramic restoration in the proper spot. And, that's big stuff. The highly nuanced stuff that we do with aligner therapy is to equate the interproximal embrasures. We all see teeth that are moved facial lingually, especially in the lower anteriors, where you get crowding there often. And somebody says, I want veneers. And you look at it and go, oh boy, I'm going to have to completely blow through the contacts, and I'm going to have to take off the full lingual of this tooth and the full facial of that tooth. And I'm going to end up with a bunch of little spikes, which is what everybody's afraid of. If you say,
Great.
I'm kind of going to have to do that to get a good aesthetic and a good long lasting, strong result here, unless we do a little bit of orthodontic treatment up front, and that will give us ideal alignment so that we can do our thing aesthetically. And, you know, we have to talk about these things with our patients. I can relate a story to you of a lady who owned the nicest women's clothing store in our whole town. Everybody knew her. She was a patient of mine, and she asked me about veneers, and I'm like, oh boy, this lady's going to be my best marketing patient ever, because she sees and dresses every woman in town and all this stuff. And I said, yeah, I can certainly do that. But, you know, I think that we should consider some orthodontic treatment ahead of time. And she said, well, why is that? I go, well, because your teeth are tipped and rotated and all this stuff, and I think we can do a better job if we do this ortho business ahead of time. And she said, okay, I trust you. Let's go. And I went ahead and did it. I got everything where I wanted. I did her aesthetic case. It turned out beautifully. At the end of it all, she looked at me and she said, answer me one question. I said, sure. What? And she said, could you have done this without orthodontics up front? And a pretty transparent guy, and I think she saw right through me. And I just, you know, I wasn't going to lie to her, and I just said, well, yeah, I could have. And then she said, so you put me through this whole ortho thing for nothing? And I went, well, no, blah, blah, blah. You know, and here I am fumbling and backpedaling and tripping over my words and all this stuff. And she left my practice, and she was not happy with me. So my great marketing scheme failed in this one. So
That backfired, sure.
yeah, backfired. Even though I did a beautiful case that she was ultimately happy with the case, she was irritated because I didn't tell her that I could have done the case without orthodontic intervention. And so the point of this, you know, here I am advocating orthodontia, you know, and obviously walking the walk. You got to be careful. You have to discuss these things, and you have to know your patient. This patient was, you know, in the disc profile, she was a very high D patient, a driver. She didn't really care how much it cost or anything. She just wanted to know how quick I could get it done. And I didn't pick up on that. You know, that was not in my toolbox back when I did this case. Today, I would have just done the case and forget the ortho, you know, just to make her happy. But you have to inform what you feel in your heart is the best thing there is to do, and I'm all about that. So we try to do the right thing first. But again, here I am, David. I told you I get off in the weeds, and you have to reel me back in.
Oh, I know. That's I think it's great because you know, our audience members are going to be up against some of these situations, and you sharing your experience has been great. But I know we've got a couple
well,
more cases to get
you
through.
can trust the fact that I've made all the mistakes. Let's say that. You know?
That's fair.
Yeah. But you know, here's another case. Obviously, could I just do a pile of restorative dentistry on this lady? Yep, I could, but I didn't. I went ahead and did orthodontic treatment for her first, and you can see in the next slide. You know, I mean, this slide you can see we've got, you know, obviously all that inclination problems and arch form. You know, she's very collapsed on her right side in the upper arch. Canines aren't in really great position. She's got some rotations, some crossbite. She's got everything, you know, you got every orthodontic malady that there is in this lady's mouth. So we said, yeah, we can do aesthetic dentistry for you, but you're going to have to go through about, you know, 9 to 12 months of orthodontic treatment first. And she said, yes. So you can see in the next slide that this is left side, right side, before and after. And is that right side, is that a perfect finish? No, it's not. Not by any stretch of the imagination in ortholand is that a perfect orthodontic case finish. But really, you have to make your decision. How far do we have to go? That tooth number 10, that incisor, that was tough to get where we got it, and open up that arch form and create spaces for all the teeth to line up with interproximal embrasures that approached, what we were looking for. And then that went on to become a nice restorative case after the fact. And then you've got some more. I think the next case is another interesting one of an alignment case. We take these photographs of these people, and oftentimes the photographs tell us where we need to go very quickly. If you just pay attention to the photographs, you don't have to know a whole bunch more that this guy bite is not where he wanted it to be comfortably. I think you can see muscular strain on this man's face, even though he's a happy-go-lucky, super healthy guy. You can see on his face that he's got some muscular strain there. So we talked to him about restoring his teeth. You can see he's aesthetically very astute. The hair is the way he wants it. He's very fit for his age. He's much older than he looks. He takes care of himself. You can tell he's whitened his teeth, at least in the front. And this guy has a high aesthetic IQ. And when I talked to him about aligning his teeth first, before we did our restorative case, he was all about it because it was going to be the best thing for him aesthetically and for his health and longevity. So this guy was kind of easy to get there. And I think you see, I think we've got slides in here. Yeah, there's certainly some occlusal plane issues, some old restorative work. You can see the bite issues and the gingival recession and bone loss that his occlusal scheme caused. So we got him into some aligner therapy and really realigned the arches first, and then went ahead and did the restorative work afterwards. And I apologize for that series of photos. It's not very good, but the next one shows where we ended up. Now, okay, what do you think? I mean, I think this guy looks a lot younger.
Agreed.
Than he did. I mean, maybe he quit coloring his hair the way he did, and it's a little whiter now. But if you look at his muscular structure in his face, around his eyes, and it's a much softer, more balanced look. And that comes from the way we correct the patient's jaw posture and muscular tension before we ever take a burr to a tooth. And what people don't understand, I hear this all the time from some restorative dentists. They say, oh, aligner therapy causes TMJ problems. They're convinced. And I just say, in my experience, the minute you start unwinding a crowded arch and a malocclusion, the TMD problems start to mitigate as soon as you start removing that engramming of the uncomfortable bite that causes the muscular problems, that causes the patient's pain. As soon as you start unwinding those stresses, they start to get away from the TMD pain as much as it has been. You have to be very careful with these cases, and I've had years of training in TMD issues and full mouth restorative dentistry, and I can kind of see the problems coming at me a lot more clearly today than I used to. So you have to be careful. But a guy like this, the case wound up so much better, and he was so happy when he was done. And like most folks his age from Michigan, he lives in Naples, Florida now. So we lose him. We lose him at some point, David. It's just not
Yes.
winter's long
Right.
up here.
Yeah, I think Florida is actually called South Michigan, if I'm not mistaken.
I think you're right. I think we're going to have the same area code on our phone and numbers soon. So
That's terrific. Well, I know we wanted to kind of get into how would someone get started, or what's really required. And I can walk through a couple of these slides, but I think where I'd really like your input is when we get to the perfect smile plan, and you as a clinician, especially wearing the hat of someone that hasn't used OrthoBrain before, or maybe has used another system, I think the color around that and how you engage with the OrthoBrain system, if we can use that word, or solution,
Mhm.
would be really helpful. But basically, like any other aligner solution, we're going to need some clinical photographs and some diagnostic imagery there. We accept STL files from any scanner, so we're scanner agnostic, and I think that's helpful. There's been so much, as you said early on, Dr. Doolin, so much development in the technology, and newer, better, faster coming out all the time. So regardless of what choice you've
Always.
made, you should be able to get a STL file too. So I remember when dentistry changed once every 15 years. I should say I'm old enough to remember that. Now it's once every 15 minutes. But
Yeah.
as you said, it's exciting for all of us what the technology can really help create.
I
So
can't
what
stress the importance of those photographs either. I think we all need to learn how to take beautiful dental and portrait photography. You have to learn it, and I can certainly direct anyone as to how to get that training quickly and inexpensively in your own office. So we have some ways to do that through the center, and it's invaluable for your diagnostic capacity and also for your case outcome.
Yeah, I would agree with you, Doctor. I think as a lay person, and we see and even create a lot of these case galleries, and I think it really, and maybe one aspect that doesn't come up as often is creating patient comfort and confidence to say yes, right? They're sort of, they're in the mood to seek treatment, but they're not quite ready to say yes. They see the beautiful before and after, and I think it makes them a little more comfortable to submit to that and say, yes, let's go ahead and get going, because I want to look like what this looks like at the end. And those the
Well, it's
beautiful
amazing.
photography really helps create that.
Yeah, I'll sit there with my assistant and talking to a new patient who's considering some of these treatments, and I'll say, "Who's this lady remind you of?" And she'll say, "So and so," without saying their full name, obviously
Mhm.
in the operatory. And I'll go, "Exactly. Will you pull up her photos for us, please?" And in my operatories have 65-inch monitors in them. So I really have an unfair advantage because I throw these big, beautiful cases up there next to their case, and they just look at me and go, that's really not fair. And I say, it
Yeah.
wasn't intended to be fair.
Sure, you're handing them the keys as they're
That's
getting the pen out.
that's the truth.
Yes. Excellent. So, what you receive in return as a clinician or practice is a perfect smile plan. We're going to see some of that here in just a moment.
Mhm.
And I think the one of the unique aspects, and maybe you can speak to this as well, Dr. Doolin, is that you do have an orthodontist review that treatment plan and create a personalized video for you. Can you
Yep.
talk about maybe how that would help you address any confidence issues you have if you haven't done a lot of clear liners before?
Yeah, that right there, that second line, the review and the treatment video, honestly, that's the whole game for me because I'm not an orthodontist and I'm not that well trained in orthodontia. So I have somebody up in the corner of my screen when I'm doing my review telling me how we walk through this. And if I have questions, I can ask questions.
Mhm.
It's a duplicate of this very exclusive relationship I had with my other orthodontist in the past. Now I have it again with some new people at OrthoBrain, and it's
Mhm.
everything that I need to have confidence to go forward with this. Because the last thing I'll look at a tooth that's rotated and oriented in some strange way and say, "Man, I don't know if I can do this." I'm not going to take on uh, conventional braces in my practice at this stage of the game. If the guys and gals at OrthoBrain tell me that I can do this case with braces and they'll help walk me through it, I'll do it because I know that I've got somebody kind of holding my hand through this that I can ask questions of. Because, you know, private practice, you're kind of out there on your own,
Mhm.
it's like they say, it's like the NFL, which stands for not for long if you make enough mistakes, right? So
Yeah, yeah.
if you've got these good people to inform you and tell you that you're pointed in the right direction, it's a whole lot less stressful and your results are very predictable. So I'm all in with
Terrific.
the ortho review and the treatment video.
Yeah, it's great
And
even as a
and by the way,
layperson. Yes,
I
sir.
share them with the patients too. I sit
Mhm,
right there and I'll run back and forth on that the treatment review, and I'll, with the slider at the bottom of the screen, you can go back and forth and
mhm,
show them before and the after, and where all the buttons have to be and where any reduction has
mhm,
to be. And by showing them this up front, I think it becomes a whole lot less scary, and they see how
mhm,
you think. And
mhm,
it just becomes, I don't know, it just becomes a lot easier for the patient to accept treatment when they can really be, informed before you perform your magic. It just makes
mhm.
perfect sense to me.
Awesome. Thank you. And I know we're going to see one here in just a minute. So I'm excited to show it to the audience. But I think it's important to remember, some cases would be aligner cases and other cases might be fixed cases. Either way, that same type of support would be available to them. So in this case, showing some aligners and what you'd receive, obviously the numbered sequence, not dissimilar to many, if not all other aligner systems out there. A lot of ways to sort of keep track of aligners and the system and where we are in the process. But I want to return, if I could, Dr. Doolin, to this
Mhm.
perfect smile plan. Obviously, on the left-hand side is sort of a dashboard look at what this case might turn out like and where that clinician might encounter
Mhm.
some situations that have to pay a bit more attention, or something pretty easy. It's meeting all the criteria. It's going to go. How would you look at this problem predictability list, and then considerations for informed consent? Forgive me.
Yeah, well, this is exactly how I look at a case, whether it's a restorative case or whether it's an implant case. I think about a case and how it's going to proceed from start to finish, and I always try to identify at least one spot that's going to be the difficult spot. What's the crux move, in
Mhm,
my treatment sequence? Where's it going to get dicey, and where, if I don't have proper patient compliance, if they're not taking care of things, if I'm not doing my job, where's it going to screw up? And if you look at this, it tells you what good, fair, and poor prognosis is. And my friend, the orthodontist, he would always have his disclaimer on all of it. There would be a lot of green in the prognosis. Then I'd see these yellow ones, and I'd see an occasional red dot, and I'd say, "Really? Are you sure?" And he'd say, "If your
mhm,
patient has perfect compliance, we'll probably do okay." And that's the truth, But at
mhm,
least you understand it. And here we go again. If you don't share these things with your patient, I think you're missing the boat, because that forces them to own their own issues. They're not your issues in the beginning
mhm,
anyway. Uh,
mhm,
our patients try to make their problems our problem all the time. And certainly we take on a lot of it and put it on our shoulders and help carry it through. But, I think you're asking for a highly stressed life if you take on all of your patients' problems and bad habits
mhm,
and inadequacies and follow through. If you take all that on yourself and say, "Oh yeah, yeah, we can make a great case for you," just
mhm,
because you want to do the case, and you
mhm,
ignore all of these problems up front to sugarcoat it and make it attractive enough so that they will accept treatment, and then you go through, and where the yellow dots are or the red dot is, doggone it, that's where the problems are going to arise. And if you haven't addressed those first, and if you can't look back and say, "Do you remember?" and you pull the piece of paper out and say, "Right here, we discussed this, and you're not
mhm.
doing your job. You're only wearing these things, 4 hours a day," or whatever. I'm just making this up, but
Right.
I think that the having the goals and the prognosis sheet there, and talking about the predictability of success and how that relates to patient performance, not just outcome of the case. So that's a great tool. And then that goes right into the next half of the slide about your considerations for informed consent, because we always have
Mhm.
to cover ourselves.
Yeah, absolutely. And there's a couple more pieces
Mhm.
here as well, if you want to just highlight those for you.
Yeah, well, when I have my orthodontist doctor up in the corner of my screen, running through this whole perfect smile plan. And I mean, these guys have done thousands of them, and I just listen to the way they speak, and they really they kind of answer my questions before they even pop into my head as we go through this thing. And I sit and watch it, and I'll listen to it, and then I'll usually go back and listen to it one or two more times and say, okay, I get it. That makes sense. And if I have questions that get raised at that point, that's when I, start my communication back and ask a specific question. But every time I've dealt with my questions have been answered before I even ask them. So this works out very well
Sure.
for me.
Excellent. I think we
Yeah.
actually have an example that of one of these videos that we can take the audience through. So I'm going to go ahead and click, and we'll listen to this for a couple minutes, and then maybe you have some comments about how that lands for you, and like you said, with the patient, if that's okay.
Mm-hmm. Yeah, he goes over all of the proper angles and lip support and all the things that our patients want to know about. Tipped posterior teeth, anterior alignment issues, occlusal plane problems, occlusal guidance in the anterior, and then you see the animated movie, and it pretty much lays it all out for you.
Yeah.
Yeah.
I think it's really important to understand how to use that best. And what I'd like to go back to is when you, especially in your first few clear aligner cases, when you have a question, do you feel that the system allows you to contact, get to support, review? Have you had an experience where you've actually had to reach out to the ortho, or do you know of many colleagues that have done that? Is there any color you can add to that part? Because I do think that clinical partnership, maybe is the best way to say it, has real value if and when you need it, right?
Yeah, I think we all want to be smart, right? We all want to have all the answers, but look at it this way. Uh, you have somebody who's going to answer your questions for you. Use them as a
Mm-hmm.
resource, even if you
Mm-hmm.
think and even if they've answered it for you, I think you can foresee questions that'll be coming your way from your patient. And that's the person that you've got to look smart in front of. So get the
Mm-hmm.
answers before they ask the questions. If you need more, get more. I haven't had too much input on it personally. I've been doing this stuff for a long time, and I'm usually kind of asking my questions up front on my workup. I would say my specific questions are, it's not more about my patient's chief complaint, it's more about my chief complaint, because I'm using this system for pre-aesthetic restorative work more than anything else. So I'm asking the questions up front. But I would say to anybody to make sure that you don't ignore this as a resource. Not only is it going to make you smarter, it's going to sell more cases for you.
Sure. Well, how do we then, and I'm just make sure my screen didn't freeze here for us. There we go. How do we then keep track? I'll add a little bit of color for the audience. There's a dashboard once you're in the portal. If you have multiple cases, you're going to see them here as you do the first one. And just talking about what you just mentioned, Dr. Doolin, if you want to communicate and get some assistance, review something for you, there's a message center there that you can engage with. You get some clinical support. Here's just some examples of the communication. You certainly can get one of our orthodontists on the phone, in text, whatever medium you choose to communicate in, and get some questions. Oftentimes it is a little bit more mundane. It might be your office team asking about a shipment or a replacement line or something like that, but it's certainly within the same business day in almost every example. So
Well, that's the
I wanted
beauty
to
of
walk
it,
through.
David.
Oh, sorry, go ahead.
Oh, I think that's the beauty of it. I mean, and if I've had two different styles of practice. I've had a larger practice with multiple team members, and communication gets lost so easily in those situations. And I'll sit there and I'll look right at my assistant and say, okay, this is what I want to know about this case. And I'm fully expecting them to write it all down, everything that I'm saying, because the minute I get up and walk out of that room, I'm going to forget all of that stuff because I'm on to the next thing, you know. And if you have a very busy practice life, you're going to blow it a lot of times, especially if you're like me, you know. And so this situation, while you're talking, your assistant can be typing these questions and typing these things right into the portal. And then, like David just said, you're going to get an answer back sometimes while the patient's still sitting there, or if not, by the end of the day. And at your end, after your wrap up, I'll say, okay, are we going to follow up with OrthoBrain? She's like, I've already got an email. I haven't read it yet, but I'm going to check and we'll go over it, and I'll call the patient tomorrow and let them know what the answers to those questions were, or she'll give me answers to my questions. It's very timely, you know. It's like texting back and forth rather than
Mhm.
making a phone call that goes to an answering machine and you don't leave a message and you
Correct.
call them
Right.
back and you forget, and now it's a week later. And we've all had that
Mhm.
happen to us in our practice
Sure.
lives. For you know, it's the way life is. But this is the these are the magical realities of our digital world, you know, and I really enjoy it. And I would say to somebody who is using your system, use all of it, you know, use those things to get the answers that you're looking for. It's going to make your life way easier and way less stressful.
Yeah, I would agree, and thank you for that background. I think that the communication aspect is so important
Yeah.
in both directions, right? We need to know as a member of the OrthoBrain team, you know, where the case is and what assistance might be required to ensure for that predictable and successful outcome. And for you also, if you have that question or your team does, just from a workflow standpoint, so things don't sort of grind to a halt here. But speaking of workflow, and before we get to some of the wrap slides, a pretty simple overview for those of you in the audience that haven't submitted something before. It's
Mhm.
fairly easy to get into this flow. Having an OrthoBrain account, which you signed up for online, a new patient Simply Clear product if you're going through the aligner protocol here, inputting that basic information along with the diagnostics that we spoke about a few slides back. Those are the photos, the X-rays or digital imagery, and then submitting the order. It's pretty simple. That gets you into a place where some of the tools that we just discussed can be used more fully. So certainly some links and things at the end of this presentation and a few slides. If you want more information, we're happy to help you. But this was more about Dr. Doolin's experience and showing some of how he might think about ortho in terms of restorative outcomes, which I thought was really interesting. And I know Dr. Doolin here in this next slide, you wanted us to highlight your relationship with Dr. Gurman, so I'll let you say a few things there if you'd like.
Well, you know, again, that's the reason that I'm here is that I had a chance encounter with Dr. Gurman. I mean, he was this guy that I kept seeing walk back and forth across the back of my lecture space and my clinical space at the center. And we met after a few times that I was there. And honestly, you don't run across too many people, number one, with the depth and breadth of knowledge that this gentleman has, but he's just truly a gentleman and a great human. And I am only here because of that, because, you know, these folks that I deal with at the center are my friends and they are my dental family now. And I'm on the phone or on a Zoom call or in their presence a lot, every chance I get. And Dan availed himself to us and said, hey, we asked him a question. You know, we had a case that we're treatment planning, and he said, well, gee, maybe we can do some ortho. Let's go ask Dan. And all of a sudden that evolved into Dan coming in and doing some guest lecturing in our courses. And I have a sneaking suspicion that there's going to be some kind of a combo thing coming up in the future. But I just want to thank you, David, and Dr. Gurman for even considering me as part of the team because you guys all do a lot to make me look good in front of my patients. And really, that's the name of the game. You know, I can't tell people enough how important it is to surround yourself with the best people that you know. There's people out there that maybe don't have your best interest at heart, or do and don't have the experience to help you get where you're trying to go. And, you know, be careful who you align yourself with out there in the world. I mean, now I'm sounding rather dad-like here, but
I'm here for it.
I can't help it. But I just want to thank you guys for your guidance and your friendship, and everybody who's listening. I hope you have as nice an experience as I've had with OrthoBrain and Simply Clear aligners. It's worked out very well for me.
Thanks for saying that. I certainly share your opinion about Dr. Gurman, both as a person and as a professional. So giving of his time and expertise, and it's been a pleasure to be a part of his team. So with that being said, I'll get to a couple housekeeping slides, and then we will say goodbye to everyone. There won't be some Q&A today. I think we've done some Q&A during it. Today's recording doesn't have a live audience, but certainly I appreciate you, Dr. Doolin, sharing so much of your experience with us. And I think we covered some sort of pro forma questions, if you want to look at them that way. I know you've been kind enough to put a link to contact you afterwards, and I'll probably highlight that as a way to ask some questions if someone who is watching this recording afterwards does have any. So there's a webinar CE process for you here. This isn't live today, but you certainly can read the slide and figure out how to get some CE here. It's pretty straightforward. But we do have some additional resources. Should you have any inquiries about this presentation or want to follow up with OrthoBrain in any way, smile@orthobrain.com is a great way to get in touch with us. You will be able to see this recording on orthobrain.com and our new resource beginning in January called OrthoBrain University, which will have a lot of fanfare and announcements around here shortly. But imagine a repository for great information like this, as well as some how-to videos, some team instruction, a lot of things, especially as a newer clear aligner doctor or someone that's new at least to the OrthoBrain solution, way to sort of get some quick assistance or to dive a little deeper if that's the case as well. Finally, I want to thank you, Dr. Doolin, for taking the time today. A nice day in northern Michigan to talk about dentistry. I appreciate you taking some personal time to do this for us, and want to thank you for your partnership and sharing all of your experience. And maybe you can talk about your contact information there and have a chance to wrap this up for the audience now.
Yeah, I thank you, David. It's always a pleasure, and I learn every case that I do, you know, and I think we all do. It's not you know, if you put you're careful to put care before commerce, you'll do well in the long run. So I think that what you guys are trying to deliver as far as your educational content is fantastic, and it just helps people like me every day. So thanks again. And if anybody wants to contact me and has a question, please feel free. I'm pretty good about answering. Just Kurt@doolindental.com, and we'll get to you, and we can work together.
Sounds great, Dr. Philip. That being said, we wish everyone a great day wherever you are in the world that you're listening to this. Look forward to having you participate with us in our web and live events in 2025, maybe even seeing you at a trade show. So